Assalamu alaikum. My name is Ahmed Hassan, roll number 179, and I am rep for batch 4. Today, in this presentation, we are going to bring forth our research article, which was a systematic type of review. Now, this presentation is going to be color coded according to the main subheadings of our original research article. These subheadings can be seen on the screen right now. All the students of my batch will present their portion of the presentation according to these subheadings. We were very lucky to have Professor Dr. Sair Afzal as a supervisor of our research article throughout the process, and we're looking forward to making some final changes to our draft and present it to the annals of chemo soon. So let's just dive right in. So the first slide is about the title, which is aptly written as Prevalence of Autism in Children in Asia, a systematic review. So it is clear that we wanted to study the prevalence of autism. And why autism? Because autism is a very serious medical issue that needs a lot of attention, and throughout the years the prevalence of autism has been skyrocketing, as you can see on the diagram on the screen right now. And we also found out that as compared to West, there has been very less work done in Asia on this specific issue, and the age group we targeted was 2 to 12 years. So we gathered and searched the literature to find out all the data that targeted our specific age group, and we wanted to summarize it according to the highest level of evidence, that is a systematic review, and that's what we did. And this title was selected according to the final criteria. Now, to provide you guys with the general summary of our work, here is a structured abstract which includes background, methods, results, conclusions, and the keywords. In this study, we used WHO's definition of autism. As for now, I can define autism as a condition that affects the developing brain, and it results in behaviorally defined static malfunctions that affects communication, language, social interactions, and a wide variety of activities and interests. As for methods, we followed the PRISMA protocols throughout our study. We looked for, gathered, and assessed all the literature that reported prevalence in all the 48 countries of Asia, and we included the studies that were done between 2019 and September 2022. According to our predefined inclusion and exclusion criteria that will be explained later on this slide, we gathered articles from all the 48 countries of Asia, and we were able to skim them down to 9 articles from 8 different Asian countries, names of which are Oman, Qatar, India, Israel, Saudi Arabia, Japan, China, and Korea. The results of our findings from these individual studies are on the screen right now. These results will be explained in detail later on in the presentation. So we targeted the age group of 2 to 12 years, and our sample sizes range from 1023 in Saudi Arabia to 1,786,194 in Israel. I would like to make it clear that due to methodological heterogeneity, this review was descriptive in nature, and the data we retrieved from all these articles was summarized as much as possible, but it was not statistically merged. So to conclude it all, our research is focused to contribute to the evidence foundation so that the future policy making can direct the resources where they are needed the most. We believe that knowing the prevalence of autism in Asia is essential for all these inevitable decisions. At the end of this slide, you can see the keywords. Next, we have the introduction. Our introduction was based on these key points that are present on the screen right now. These key points are the opening passage, the general literature, the specific area of focus, and the unanswered question in that specific area, and it ends with our research question. So this is our introduction. Up till now, I have established that autism is increasing day by day, and I have also defined autism. In the previous literature, we found out that in Asia, the overall prevalence of autism is 0.36%, and it is still rising. The specific data in different Asian countries can be seen in the first paragraph right now on the screen. The main points are: in China, the prevalence is 0.29%. In India, a study revealed it is 0.11%, and so on. You can see all this data in different countries. I won't go into the details. I would like to establish that in all the 48 countries, we didn't find a study that summarizes all this data in a very systemized way, or if it is done, it is very outdated. So the prevalence, the specific targets, the time-bound comparison of incidence of autism in many Asian countries are still unknown, and the aim of our study is to highlight the scarcity of knowledge about autism. This study will have to add to the evidence database that will be used in the future decision making. So this was all about the introduction. For next part, I would like some of my other colleagues to take over.
Roll number 181, Ahmed Shahroz. I will be presenting methods. First of all, definition of autism spectrum disorder. According to WHO, it is basically ASD constitutes a diverse group of conditions related to development of brain. There is some difficulty of social interaction and communication, also atypical behavior and pattern of activities. There is unusual focus on small activities or small details and unusual reactions to some sensations. So next is search strategy. Search strategy, we preferred PRISMA guidelines, and throughout the whole research we adhered to the PRISMA guidelines. And for this there was an extensive systematic research for 4 electronic databases, namely PubMed, Medline, Inari, the Cochrane Library. And in this, the studies between 2019 and September 2022 were chosen and further selected. For search, a combination of following terms were used. 1. Population, Asia, children. Category 2. Disease, autism, autistic spectrum disorder, autistic disorder, Asperger disease, and Rett syndrome. Category 3. Prevalence or epidemiology. With above criteria mentioned, a number of articles were found and they were critically analyzed. Further, we manually searched the articles from the reference list of above search articles. And these articles were reviewed and the duplications were removed. Thank you.
Roll number 182, Ahmed Uzair. I will talk about the inclusion and exclusion criteria. They are the characteristics of an article or study that define whether it can help you answer your research question. In other words, they are the criteria you use to decide whether you will cite an article or not. First, the inclusion criteria. Number 1, patient population. Studies focused on children aged 2 to 12 years. Number 2, individual studies with original data including grey literature were included. Number 3, definition. The studies that agreed with the defined diagnostic criteria stated for autism or autism spectrum disorders. Number 4, prevalence. Prevalence is the total number of individuals in a population who have a disease or health condition at a specific period of time, usually expressed as a percentage of population. Number 5, language. Studies which were available in English or could be translated to English were included. Number 6, geographically defined population. In this case, the Asian residents. Number 7, time duration. Studies done between 2019 and September 2022 were included. Moving on to the exclusion criteria. Articles were excluded on the following basis. Number 1, studies which weren't extractable, for which you couldn't get the full text or they were inaccessible. Number 2, unoriginal studies such as editorials, reviews, and commentaries. Number 3, qualitative studies were excluded. Number 4, the studies which weren't of interest. The theme of the study was different and our focus of result was on something else. Thank you.
Assalamu alaikum. My name is Amna Khalid, roll number 19, and the topic of my discussion is quality assessment. Basically, quality assessment refers to the assessment of methodological quality and rigors of the trials and studies included in systematic review. So, in our research paper, first of all, each paper was screen share नहीं हो रही.
Please continue.
In our research paper, each paper was initially screened and analyzed separately by two authors before being included or excluded. Articles were further evaluated by four other authors to see whether they met the inclusion or exclusion criteria. The title and abstracts of each publication were initially reviewed to see if selection criteria were met. The complete text of any articles that didn't fit these requirements weren't obtained and were excluded. When there was a difference of opinion about eligibility, the four authors reasoned and decided whether or not to include or exclude that specific article. Additionally, the included studies were assessed for quality by Joanna Brick Institute Critical Appraisal Tools for Prevalence Studies. All studies that fulfilled the eligibility criteria were included in the review, regardless of their quality assessment results. So we selected 9 articles. Out of these 9 articles, 6 were of very good quality, 1 was of good quality, 1 was of average quality, and 1 was of poor quality. Next slide. So following points were considered in quality assessment. First is the Joanna Brick Institute score. Was the sample frame appropriate to address target population? Were study participants sampled in an appropriate way? Was the sample size adequate? Were the study subjects and the setting described in detail? Was the data analysis conducted with sufficient coverage of the identified sample? Were valid methods used for identification of condition? Was the condition measured in a standard, reliable way for all participants? Was there appropriate statistical analysis, and was the response rate adequate? And if not, was the low response rate managed appropriately? Thank you.
Assalamualaikum. This is roll number 20, Amrut Sabur, and I'm going to discuss about PRISMA. Throughout our systematic review, we have followed PRISMA guidelines, called PRISMA is a recognized standard for reporting evidence in systematic reviews. It includes 4 steps: identification, screening, eligibility, and inclusion. So for identification, we used 4 different electronic databases, which are PubMed, Medline, NARI, and the Cochrane library, and we found a total of 338 different articles from these databases. Out of these 338 articles, 201 articles were removed as duplicates, and we were left with 137 different articles after this duplicate removal. After comparing with our inclusion and exclusion criteria, these 137 articles were screened on the basis of their titles and abstracts, and 128 articles were excluded. The remaining 9 articles, we further assessed them for their eligibility on the basis of their full text, and no articles were removed in this process. In the end, we were left with only 9 articles, which we incorporated in our study and used for further data extraction. Thank you.
Assalamualaikum. My roll number is 21. These tables contain all the data that was extracted, and these tables are tabulated by author name, year of publication, journal name, country, setting, population size, male, female, study design, outcome measures, age ranges, prevalence, and main findings. As we can see from these tables, as these tables represent that the countries that from which articles were selected are Oman, Qatar, India, Israel, Japan, Korea, and China. And the settings the settings in which these articles were done were mostly community based, for 2 articles the setting was hospital and diagnostic centers, and the article was, and the study design which was used in most of these articles was cross-sectional study, along with 1 or 2 articles which used retrospective cohort studies, and the outcome measures. The outcome measures which were used in these articles were mostly DSM and DSM-5, DSM-4, and QCCAF, and the age range was from birth to 16 years maximum. And the main findings are will be discussed in the results.
Thank you. So basically, in the tabulation part, we have all the data that we extracted and used in discussion and results part, and Anusha was trying to summarize all of it. So moving on, in the results, these tabulations were also used, and the Prisma was also presented in the results part. So please continue. Who is going to be the next?
I'm Taiba. As a roll number 22, I'm going to present the results study. In the slide shared on screen, there is a region-wide summary of ASD prevalence. In Oman, it is 0.2035%. In Korea, 0.52%. In China, combining the results of two research papers, it was 0.4272%. In Saudi Arabia, it is 0.281%. In Qatar, 1.14%. Japan, 3.22%. India, 0.225%. And in Israel, 0.655%. So we could easily conclude that ASD prevalence in Asia ranges from 0.655 in Israel to as high as 3.22% in Japan. And on average, ASD prevalence in Asia, according to our study, is 0.78%. In the next slide, shows the gender-wise summary of ASD prevalence. As you can see on the leftmost side of the ratio of boys to girls is as follows. In Oman, it is 3.4:1. In India, 1.11:1. In Japan, 2.2:1. In Korea, 2.7:1. Chart below shows the similar ratios. On the rightmost corner, there are some pie charts used to represent the same boys to girls ratio in the form of percentages. In Oman, it is 22.7% girls and 77.3% boys. In India, it is 47.4% girls to 52.61% boys. In Japan, 31.2% girls to 68.375% boys. In Korea, it is 27% girls to 73% boys. This overall concludes that boys have a higher risk of ASD than girls. In the next slide, the bar charts on the top left shows the ASD prevalence per 10,000 children. In Oman, it is 20.35 per 10,000. In Korea, 5.2 per 10,000, and in China, 10.8 per 10,000. And in the bar chart on the top right, ASD prevalence is depicted per children. It is 2.81 per 1,000 in Saudi Arabia, 6.55 per 1,000 in Israel, 2.25 per 1,000 in India. Similarly, in the bar chart on the bottom, ASD prevalence is shown in the form of percentages. It is 1.14% in Qatar, 3.22% in Japan, 0.29% in China. And in the next slide, there are some pie charts representing boys to girls ratio. In Oman, India and Saudi Arabia, it is 9.07 per 10,000 girls to 31.23 per 10,000 boys. In India, it is 47.36% girls to 52.63% boys. And in Saudi Arabia, it is 27% girls to 73% boys. This concludes that average prevalence of autism spectrum disorder in China from the research papers published between 2019 to 2022 is 0.78%, with boys having 3 times higher risk than girls. And then over to Afa for the discussion part. Thank you.
Assalamu alaikum. My name is Arfa Tahir, roll number 24, and I'm going to present a discussion portion of our research article. During the last decade, there has been a dubious increase in the prevalence of autism spectrum disorder diagnosis around the world. But most of this work has been done in the West. There is a significant lack of information about prevalence of autism in Asia. Our journal collects all the information about prevalence of autism in Asia and includes the journals that have matched the outcome results of our topic. Total of 338 articles were found to have reported prevalence of autism in Asia. After screening using our inclusion-exclusion criteria according to PRISMA guidelines, 9 articles were finally selected. This included 2 articles from China, 1 from Oman, Qatar, Israel, India, Saudi Arabia, Korea, and Japan. In 2019, a study was conducted in Oman on a population sample of 1705 individuals ranging from 0 to 14 years, and highest prevalence was found in Muscat. Boys were found to have a 3 to 4-fold higher prevalence of autism spectrum disorder than girls, and the prevalence was found to be 15-fold higher than 2011 estimates due to improvement in screening programs and diagnostic criteria. In Qatar, a population sample of 176,000 people was taken and prevalence was found to be 1.14%. It had two components, a school component uniquely due to newly diagnosed cases, accounting for 28.1% of overall prevalence. Next slide, please. In India, cross-sectional study was conducted having a population size of 8,400 individuals and prevalence was found to be 2.25 per 1,000 people with a rate of 52.63% in males and 47.65% in females. It was a population-based study having a sufficient sample size and low response rate. And a study from Kolkata scales translated from Western scales used PPS method for sample size and stratified sample technique to have representative sample from rural urban areas. In Israel, cohort study was conducted using DSM-TR criteria and prevalence was found to be 6.55%, but it varies among different regions of Israel. High socioeconomic localities reported higher prevalence than those of their sub-district localities. This pattern of central prevalence seemed to be steady over years. Arab localities were found to have threefold lesser prevalence, mixed one have intermediate and Jewish have high prevalence. In Saudi Arabia, prevalence was found to be 2.81 per 1,000 people in children aged 6 to 11 years attending schools as rehabilitation centers in Makkah and Jeddah. The increased prevalence is associated with some genetic environmental factors. In Saudi Arabia, this is because that the rate of cousin marriage is high. In Japan, cross-sectional study was conducted on a group of 3,954 individuals with prevalence of 3.22% over age of 4 years, and male and female ratio was found to be 108 per 1 lakh using caste DSM criteria. In Korea, prevalence was 5.2 per 1 lakh people, 2.7 times higher in boys than girls. In China, again, a study was conducted using cluster sampling and prevalence was found to be high in boys. So the limitations of our article are that different screening and diagnostic tools were used to find out the prevalence in different countries, which makes it difficult to compile and compare the data. Google Scholar is not used for this review, so some articles may not be included. Prevalence is not universally calculated because population size is hospital-based or consisting of school population. And the strengths are that data from different countries, 8 different countries was included in this review, which makes it able to generalize. So thank you.
Thank you, Arfa, for presenting us the discussion. Moving on, we have the references. Now, I didn't add all the references that we used in our research article so that the presentation does not become too long. But what we did was we used the Vancouver style of referencing. A quick mention of Vancouver style is necessary because one of the main reasons of article rejection is incorrect referencing. So what we did was there we used the Vancouver style, and here is an example of how it's done. First of all, you are going to write the number of the reference, which is followed by the last name initials in retail, of course, then the title and subtitle of your research article, which is followed by the name of the journal in which it was published and the year of publication. Then comes the volume number, the issue number, and the number of pages on of the journal in which your article was published on. And if you this was for an original study, if you're using a reference from an original study, and if you are using data from a website from the internet, you are going to add the references as can be seen on the screen right now. So now I'm going to show you how our original article looks like. So this is how our article looks like. And from here the references start. Thank you for listening to us so patiently, and now the panel is open for questions.